Hello and welcome to Health Styles. I'm Connie Mead. February is National Heart Month, and with this in mind, we are continuing our discussion of staying heart healthy. Cardiovascular disease is the #1 cause of death for all men and women in the United States. And as we get older, it's only natural our likelihood to develop this condition increases, but there are steps that we can take to prevent it. So today we turn our attention again to our heart health, and we learn some practical advice about preventing a heart incident, but also more importantly how to respond to one. So I have two guests I'd like to welcome to the program today who will be joining me for our discussion, and the first is Dr. Richard Birkhead, who is the Chief of Cardiology and the Medical Director of the Heart and Vascular Center at Lowell General Hospital. Dr. Birkhead practices cardiology with the Merrimack Valley Cardiology Associates in North Chelmsford. He's board certified in internal medicine and cardiology. He participates in clinical trials to advance the knowledge of cardiac care for all patients, and he's also a certified cardiac device specialist as well. So in addition to Dr. Birkhead, we have Mr. Tim Regan, who's also here to assist in our discussion. And Mr. Regan is the Director of Emergency Medical Services and Advanced Life Support for Lowell General Hospital. And he also oversees a team of dedicated emergency responders that serves 7 communities in the greater Lowell area. So I want to thank you both for coming in today and joining us here on the program.
Glad to be here.
Excellent. Okay, so I want to start with you, Dr. Birkhead, just to get us started a little bit, maybe not right on topic right away, but I also read in my research that you performed the first cardiac catheterization at Lowell General Hospital back in 1991 when Lowell General opened its cardiac catheterization lab. And so I just wonder if you'd reflect a minute on those last, 23 years and kind of just tell us, what surprises you about the level of care.
Sure, that's a while back. I'd just come out of training from Boston, and we wanted to get Lowell a little bit up to speed in cardiology. So we opened a diagnostic cardiac catheterization laboratory where we take pictures of the arteries of the heart and find out if there are blockages, are they at risk for heart attack, should they have angioplasty, stents, or bypass surgery. In the last 10 years, we've actually grown a great deal. We're doing angioplasty not only for acute heart attacks, but also elective angioplasty for angina syndromes, and we're now a big booming operation, I'm glad to say.
Okay, so, and the technology has definitely helped patients, I'm sure, over all these years.
Over that period of time, it's the same procedure, but every little bit of technology has improved. Our approaches are better, and I'm glad to say that our patient results are showing the good results as well.
Okay, so a lot of continuous improvement there.
Yes.
Yes, okay, excellent. All right, well, we really want to focus today on, heart disease. We'll probably do a little recap of what heart disease is, and and talk about some of the major heart events that someone might experience, say at home or at work, and how to deal with those. If you haven't caught the first part of our series, if you will, on staying heart healthy, I encourage you to go online to chelmsfordtv.org, where you can see the first part of our February American Heart Month, if you will, programming, and that can give you some more background to what we've already discussed. But just to recap, let's just talk about heart disease and what it is. Can you just give us a brief overview?
Well, heart disease is the #1 medical illness in the country, in the Western world, and it is primarily atherosclerosis, which is clogging of the blood vessels that supply blood and oxygen to the heart itself. It's a cholesterol plaque forming in the arteries, clogging the pipe, limiting the blood flow, and causing a variety of things from heart failure to angina, chest pains, to heart attack and sudden death. Okay,
so all of these things are all caused by a buildup of plaque?
Yes.
Okay. And I think we might have a visual of that, what that looks like when plaque builds up in the arteries, just to give people an idea about that. After the last show, I was thinking that we do with Dr. Ali, I was thinking that the heart is almost like the Grand Central Station, if you will, but it's what's happening on the tracks that is what's derailing everything. Would that be an appropriate analogy?
It's very important to my perspective. If you asked a neurologist, he'd say the brain is the most important part, but I think it all has to work together, and you have to have the arteries giving the blood supply nutrients to the heart for it to work at all.
Okay, okay, all right. So so that kind of gives us an overview there, and you say that buildup of plaque can lead to, you said, heart attacks, angina?
Heart failure and sudden cardiac death.
Okay.
Because of creation of arrhythmias, if the heart isn't responding to muscle contraction appropriately, if the electrical system is out of whack, the heart can virtually stop, and that's where we get into people like Tim to help out and jumpstart the heart.
Okay, all right, so let's talk about, say, one of these major heart events. Let's talk about a heart attack. That's probably the most common, would you say?
Heart attack is very common. We see them, often several a day in a city the size of Lowell. What's happening is that cholesterol plaque, the lining of the artery, has cracked open, ulcerated, and a clot has formed. The clot then blocks the artery totally. That area of the heart muscle doesn't get enough blood flow, and the patient perceives pain or chest pain or shortness of breath at that point. Right,
right. And I think one of our visuals also kind of indicates that, where it's really when there's that plaque there and the clot together almost seem to be the problem.
Together,
I
mean, yeah, if you have just the plaque alone, like on the second phase there, then it may not be causing a heart attack, but it all comes to a head when clot forms on a cracked open plaque. The clot then blocks the flow of blood cells through that narrowing, and that causes, well, if it's in an artery to the brain, it would be a stroke. If it's in an artery to the heart, it would be a heart attack.
Okay, all right. So we want to prevent that buildup of plaque, first of all. That's
Correct.
The main thing.
Correct.
Okay, so that whole scenario doesn't
And when the
develop.
plaque's there, we want to keep the lining of the plaque healthy so it's less liable to crack open and form a clot.
I see. And how do we do that?
Well, we make sure that our cholesterol and sugar are appropriate. We make sure we take an aspirin if you have plaque there to prevent that clot from forming on an ulcerated plaque, and we cross our fingers.
Okay, all right, okay. So, all right, but these events do happen, as you say, several times a day. You're dealing with this at the hospital. Yes. But the first person who's likely to see someone with a heart attack is someone like Mr. Regan here. So, first of all, let's back up. What are the symptoms, if you will, that should cause a call to you for a heart
I think any
incident?
patient that suddenly experiences some chest pain or an acute onset of shortness of breath, even some nausea or sudden weakness, something that's totally out of character for what their normal daily activity would be, that should trigger a little signal within themselves to think, gee, I might be having an event. I should probably think about calling my doctor or activating 911. So we see patients that have the crushing chest pain, the pain to their left arm, pain to their jaw or to their back between their shoulder blades. For many of those, it's something so new and so abrupt and intense that will trigger them to call right away. But there are other folks that present in a different fashion that don't necessarily have those symptoms, but they may have some sudden weakness or some nausea or just suddenly break out in a sweat. I don't think everybody fits the mold of having just the pain with the arm. So they should think about these things and perhaps call 911 and at least activate our team and get the system rolling so that we can get to the location and evaluate the patient, make sure they get to the best place they need to go.
Very important point, not to drive to the hospital yourself. A lot of people die in the car on the way to the hospital. Big problem. If you have chest pain, call 911, get somebody like Tim there right away.
Okay. Right, because what's going to happen, what's the problem with driving yourself? I mean,
you may develop a heart rhythm disturbance, you may not be able to drive, you may faint in the car, you may die in the car. If your family member is driving you, they cannot resuscitate you. But if you have the ambulance at your house within 3 or 4 minutes, if you then have one of those bad rhythms of the heart called ventricular tachycardia or ventricular fibrillation, they can use their defibrillator to shock your heart restore your heart rhythm and restore your life.
Right.
You can't do that in a car on the way to the hospital.
Right.
And you know, also there's a maxim that says time is muscle. So the longer it takes to get definitive care for that insult that's happening to your heart, the potential is for greater damage to the muscle. So if we're there in that time that a loved one or somebody will be driving you to the hospital, we're actually initiating care at the patient's bedside. So that time is being decreased. So we're actually doing many of the things that we'd want done before they went to the catheterization lab, we're doing en route, or resuscitating the patient if that's what's necessary. So it's time well spent.
Okay. All right. I just want to back up on one thing you said. You talked about some of the symptoms. Now, I've heard that the symptoms women have during a heart attack are sometimes different from what a man experiences during a heart attack. Is that accurate?
It is accurate. Women and elderly people sometimes present a little bit differently, and that is out there in the literature. But most women having a heart attack will have chest pain, nevertheless.
Okay. All right. So that's a dead giveaway right there.
And for many of these folks, too, they're having a different presentation other than the crushing chest pain, but for them it's something they detect as being abnormal for them, and that's what's getting them to call for their further evaluation.
Okay. And if you're not sure, you should just call anyway.
Just call anyway.
Okay.
We're around 24 hours a day, 7 days a week, so we're glad to come out and help, you know, get people to where they need to go.
Okay. All right. And so then let's say that, you know, within 3-4 minutes you're at my house. What happens then?
Well, your care actually begins when the call is first made, and I'll just use let's use a sudden cardiac arrest scenario in somebody's home. That first call to 911 goes to a set of trained dispatchers. They gather the information, they find out where the location is, they get some patient identifiers and demographics, and then if something like CPR is required, they'll actually start coaching the family members or somebody there on how to perform CPR. That continuum of care will flow through to the first responders that will arrive on scene. It might be a police officer, it might be a fire company. They may not have EMTs on board, but they do have, you know, CPR certified and first aid certified personnel. They'll continue the care, and then along with that, you'll see the ambulance that will arrive with the basic life support providers, and then following that will be one of the folks from our department who is an advanced life support provider. So what we have in this service area is called a tiered response.
Okay.
So when you make that call to 911, you set into place a cascade of responders that are going to come to your home or where the incident is, and if advanced life support is not required, then the ambulance is able to cancel us and stay strictly at the basic life support level, freeing up that advanced life support unit to go to another response in the areas they are needed. And if it's just something that the fire department can handle by themselves, they in turn can cancel the ambulance.
I see. Okay, so that was kind of what I was thinking, because if it's something that's not critical after all, you don't necessarily go all the way through to the hospital. Somebody will make an assessment and say, well, no, you know, this is not necessary.
For some injuries, that's true, but when it comes to an incident, especially one involving the heart or chest pain or shortness of breath, even though we have some fantastic tools out there in the pre-hospital arena, it doesn't replace a physician evaluation.
Okay.
So even though we'll get there and we may not continue with the lights and the siren to the hospital, but we still need to get that patient to an emergency room for an evaluation.
Okay, to see what is going on.
Correct.
Right, okay. And now while you're in the ambulance, something is going on, or the patient is just resting, or?
Well, we begin all the care that you'd see in the emergency department right in the ambulance or at the patient's bedside in their home. If it's indicated, an intravenous line will be started. An EKG will be performed. We'll do some evaluations on the patient's oxygen saturation in their blood, provide oxygen, give medications as required, package the patient, and hopefully alleviate some of their anxiety and their concern, make them comfortable, get them to the ambulance, and then take them to the emergency department.
Okay, all right. Okay, so you get them to the emergency department. Is there communication that between?
There's a communication en route to the emergency department, and once we arrive there, when we're inbound to the ED, we'll make a phone call or a radio call letting them know what we have, what we've done for the patient so far, and what they can expect when we get there. When we arrive at the emergency department, they already have a lot of that information, so they can base where the patient needs to go within the emergency department. Or in the case of a patient having an acute heart attack, we may be able to bypass the emergency department directly and go directly to the catheterization lab. But for the most part, in either location, there's an orderly transfer of patient care where the information is given and the receiving physician and staff accept the responsibility for the patient from our pre-hospital providers.
Okay, all right. And so now they're at the emergency room, they're being evaluated, or maybe they've just been whisked up to the catheterization lab. Does everybody go through, you know, who's is suspected of having a heart attack go right up to the catheterization lab, or do they stop and
well, it
do some
sort of
assessment?
depends what kind of heart attack we're talking about.
Okay.
Those where it's a clear-cut heart attack, and you can usually tell that on the electrocardiogram, the EKG, those patients are whisked away to the cath lab in a big hurry. And the point of that is we need to open that artery as quickly as possible, and we need to do that within a period of 90 minutes. So we call it the door to balloon time. The time they come in the door of the hospital to the time the balloon opens the artery, we want that definitely under 90 minutes. That saves lives, that saves heart muscle to do that.
Okay, and so you mentioned the EEG, what's it?
EKG.
EKG,
Electrocardiogram measures the electrical impulse of the heart and actually is pretty good at diagnosing many heart attacks. There are a lot of little lesser chest pains, we're not quite sure what they are. We may take our time and sort those out, which may require blood testing, may require stress tests, that kind of thing, or other tests. But if it's a clear-cut heart attack, we go into action, we're in a big hurry, and we have a great setup to do that in a big hospital like we have now.
Okay, all right. And are you doing the EKG in the ambulance, or is that in the hospital?
We're doing it in the ambulance and at the patient's bedside. What we're doing is we're taking a snapshot in time of that patient. There are some circumstances where a patient's chest pain may be stuttering, where they're having the chest pain, where we can detect those electrocardiogram abnormalities, and then it may resolve itself a little bit, and then that change that we saw in time may go back to a normal EKG tracing. But it's very important for us to have that snapshot right when the patient was having that discomfort. Let's be able to provide that to the cardiologist when they evaluate the patient.
Okay, all right. So, all right, well, let's talk a little bit more about the catheterization procedure, if you will. And I think we might have a graphic that shows kind of what happens, at least to the artery that's affected. Sure. So you decide that somebody, is in need of going to the cath lab, and so what happens then?
Well, assuming we're not in a super hurry, we will get an informed consent from the patient. We'll make sure everybody knows what's going on. We'll give medications to relax the patient. Then we'll figure out how we're going to access the heart, and often these days we're able to access through a small tube in an artery at the wrist, a pulse at the wrist. And we put a long tube up to the heart when we're watching under X-ray, and it's very comfortable. The patients do not have a lot of pain with this test at all. And we inject a liquid that shows up on the X-ray, we call it contrast, into the arteries of the heart. And the blockage doesn't show up unless you put in this contrast that shows the artery, and if there's a blockage, it sort of abruptly stops. So you're seeing the inside of the artery. You're not actually seeing the plaque itself, usually. Then when we've taken pictures of the arteries to the heart, there's usually a left and a right, we take a picture of the heart muscle and see what damage there is or what damage is threatened. And then we sit down, well, we're doing this in a big hurry usually, but we decide if we need to fix something, should it be with a heart operation, in which case they may need to leave town and go to a large hospital where they do heart surgery, or we may decide to fix one of the arteries with a balloon and a stent. The interventional cardiologist specifically does that.
Okay, so I think that's what we had the graphic on here, was the balloon and the stent.
Yeah,
right.
So the balloon and stent are collapsed and they travel along the small tube that's placed in the artery. The balloon then expands. The stent is like a wire mesh that sort of, we open it up and you leave it there. You then remove the balloon and hopefully the artery is left open. The plaque is pushed to the side so that there is a nice pipe open for the blood, the oxygen, to make it to the heart, and you're then restoring blood and oxygen to the heart muscle, the part that was threatened by the heart attack.
Okay, so if we look at our graphic here, it's really the middle one is sort of the beginning of
the middle one
the
is
procedure.
a problem, yeah, and the balloon is collapsed and the stent is tightly around it so that it can fit there, but then the balloon is expanded, it's filled with a liquid, and then it leaves the expanded stent in location. So the stent stays, the balloon goes, hopefully the artery is left open, and hopefully you've gotten rid of any residual clot that's there.
Okay. A couple of minor questions. Now, what started this whole thing, what triggered the event, was a break in...
A break open of the lining of that plaque in the artery, to which a clot then set
adhered.
up housekeeping, adhered, and then totally blocked the artery, yes.
Right. So when we do this, does it somehow close that breakage where that break in the lining occurred, or how does that mend itself?
Yeah, it smushes it all to the side.
Okay.
We give a lot of medications directly there that help prevent further clot. A lot of the clot breaks up and goes downstream. We have to deal with a lot of special other technical issues. The artery may sort of fill up with debris. We can cause spasm. All sorts of things may happen. And hopefully we're left with a stent that holds the artery open, and most of the clot is gone and most of the heart muscle is preserved.
Okay, all right. Now, the patient who's gone through this, I assume they have to stay in the hospital for a little while?
If they've come in with a heart attack,
yeah.
A major heart attack, and if they have this done, they're then transferred to the intensive care unit, where usually they're comfortable, they're feeling better, and everybody is very much relieved, and usually it's kind of a boring 2-3 days afterwards. It used to be that people were kept in the hospital several weeks after a heart attack like this, but now we open up the artery, we've identified the heart muscle strength, we get them on the right medications, and there are 3 or 4 that they definitely need to be on at that point. We often evaluate the heart muscle strength. We make sure they don't have rhythm disturbances. We treat heart failure if they have that. We get them up and walking around in another day or 2, and they're usually home in 2-3 days.
Okay, all right. And then they're following up with their cardiologist and rehab and all of that, I assume?
Often we get them involved in a cardiac rehabilitation program. We have a good program at the hospital, and so they'll go 3 times a week, and they'll walk on treadmills, and they'll lift a few light weights. They'll learn about what diet they should have at that point. They'll learn about their medications. The nurses check their blood pressure, monitor them for symptoms and other problems. It's a good experience. They enjoy it. They usually take it easy for a little while. They may stay out of work for a while, depending on the size of the heart attack. It's a common enough problem that we're getting pretty good at dealing with it.
Okay. All right. So, and then the person is on their way, and hopefully that's the only time they have this kind of an event in their life.
That would be good. And hopefully at that point we're talking now about secondary prevention, we call it. Primary prevention would be we're trying to prevent it in the first place. Secondary prevention was already happened. We're trying to prevent it from happening again. So we're going to have them stop smoking. We're going to make sure they're on the right medications. We're going to make sure their diabetes or sugar is really well controlled. We're going to make sure they're on cholesterol lowering medications. We're going to make sure their blood pressure is perfect.
Okay, all right, okay. I want to talk too for a minute about the event that happens sometimes where somebody, say, collapses, maybe in a public place, and they need somebody to help them in the meantime. We talked about doing CPR at home and being kind of talked through it by the dispatcher, but we also see these AEDs in public places. I know Chelmsford has them, I think, in all the schools and the libraries and that sort of thing, and I know you brought one with you here, Mr. Regan. So I don't know if you'd like to just give us a quick update on, when is it appropriate for this to be used, and who should use it?
Well, this device, an automated external defibrillator, is a device that's used for those patients that have collapsed or are suffering a cardiac event where there's an electrical disturbance in their heart preventing it from pumping effectively, whether it's ventricular fibrillation or ventricular tachycardia. This device is used for patients gone to the ground and they're unresponsive. Whoever's coming to provide aid to them, if they're CPR certified, will know how to use and deploy one of these. They will evaluate the patient to make sure that they have a circulatory effort, they have an airway, and that they're breathing. For many folks out there, they would remember years ago that the mnemonic for CPR was ABC, airway, breathing, circulation. Over the years, some really good data has been gathered, and the correct, or what they're finding to be a more proper mnemonic is CAB, which is circulation, airway, and breathing. So the patients evaluate to see if they have a pulse at all. If they don't have a pulse, chances are they're not going to be breathing whatsoever. So rather than delaying and listening and feeling for a period of time, people are instructed to start compressions right away. While that's being done, somebody else may go and get one of these defibrillator units. This arrives at the patient's side, it's opened, and inside are a set of pads. These pads are placed on the patient's chest, or according to the instructions, either chest on an anterior placement or anterior posterior placement, and they're very simple to use. It's the power goes on, the patient or the rescuer is told to stop CPR, analyzing. This machine will analyze for those rhythms that we discussed that need electrical therapy to correct them so that the patient hopefully can have their own intrinsic heart rate start up again. And if a shock is indicated, it will actually charge the unit and it will tell the rescuer to depress this button, at which point the electrical charge goes through these pads into the patient's heart, hopefully resetting the circuit breakers, as it were, and hopefully the patient's heart can start beating again normally. These devices are in many public buildings. They're in schools. By mandate in Massachusetts, they're in health clubs and in dentist office. But as far as towns go, it's pretty much a town initiative to see if they're going to be a heart-safe community and get these into all the public buildings and in all the athletic fields and all the sporting arenas.
Right, right. I know Chelmsford has them in public buildings. I don't know about, you know, the fields and that sort of thing. Maybe there's somebody there. So let me just back up, though. So the machine talks you through it. So it's not as if you have to do a lot of decision making. You just have to know how to put these pads on.
Correct.
Right?
Correct. If you know CPR, and if you've ever done it before, you know it can be a little chaotic and very overwhelming. You're trying to help this patient. With these devices, no matter the manufacturer, when you apply them to the patient, they will talk you through it in a very loud, firm voice. And it's very helpful to hear that because it reminds you to do certain things in the proper steps. After this tells you to deploy a shock, it will then coach you through another 2 minutes of CPR before you even check to see if there's a pulse in the patient, to see if you need to charge it again or if it needs to be, the rhythm needs to be analyzed. So these units are fantastic. They've helped my job, made it much simpler getting patients to the hospital alive than we've ever seen. So I would suggest that anybody that is watching the show that might want to take a CPR course, learn how to use one of these and to be able to provide aid to somebody if it's necessary, to go onto the Lowell General website or to contact the hospital directly for instructions on how to sign up for a course.
Right, right. I think we have some of that information up here now about, you know, calling the Lowell General website or telephone number or website. And right, so there is CPR AED training. I think that's given every month from what my notes tell me. So
yes.
It's easy enough to become trained on something like this.
Correct.
And we all should know how to do it, right?
We should.
Right, okay. All right. And I know that there's also going to be a free health fair on March 1st. I know by the time some of you watch this, that will all may have gone by, but you can get a lot of that same information at their regular cardiovascular screenings that they do also over there. I think it's once a month as well. So you might want to check out that as well. There's one other thing that I know our graphic shows up there that talks about something called a calcium, or is it a CT calcium scan? I may not have the name right. Okay.
You got it.
So what is that? And it's something I understand is not covered by insurance, and you don't need a doctor's referral. What is that, though?
Well, if you're watching this program and you want to know if you have heart disease, if you have what might turn into a heart attack or something like that, you might just think, well, what can I do to know? I don't have chest pains, but you know, my father had a heart attack and I actually do have a high cholesterol, maybe I'm a little overweight. You want to know if you are really at risk for heart disease. Maybe you have some pains. It might be appropriate that you have this test, which is a CAT scan. It takes literally 10 minutes. They measure the amount of calcium in the arteries of the heart. If there is a lot of plaque, there's a lot of calcium in the arteries. So if you're lucky and you have this test, your score might be 0, which would indicate you really don't have any plaque, good to go. Don't worry too much about your weight perhaps. If your score is very high, you might want to discuss that with your doctor. At certain levels, you might want to have a stress test. At certain levels, there may be a chance that you have a blocked artery and you want to look into it further and talk to a cardiologist. Yeah, the insurances don't pay. The hospital does allow $100 for it if you want to come up with that. Not everybody should have this test. If you're young and relatively healthy, there's probably no reason. If you're really old, and many people have plaque at that age anyway, it's not going to help you very much. But if you're in an intermediate category, maybe you have some atypical symptoms, it may be a useful test for you.
Okay, all right. Well, I think we'll have to leave it at that. You've given us a lot of valuable information in terms of understanding the heart attack event and you know, what we should do, and I thank you for that. And I thank you for joining us this evening as well. Thank you. See you next time.
Thank you very much.
Thank you for coming in.